Okay, so good evening to everyone. Today we have a very special presentation on Epistaxis by Dr. Chythanya, and she is my UG batchmate. She's a very smart person, much smarter than me. So I'm sure this is going to be a wonderful lecture. She's an MS in ENT. She did her PG from Osmania Medical College. Now, without further ado, we'll give it over to her, and she will take the lecture.
Good evening, everyone. Myself, Dr. Chythanya. I'm working as a senior resident in the Department of ENT in Osmania Medical College, Hyderabad. First of all, I would like to thank Dr. Mehul for giving me this opportunity. So today I'll be dealing with the ENT aspects of management of epistaxis. So my presentation includes an introductory part, vascular and endoscopic anatomy of nose, key clinical areas which are significant in epistaxis, classification of epistaxis, causes of epistaxis, and most importantly, management of epistaxis. Coming to the introductory part, epistaxis is a Greek word which means bleeding from the nose. It is one of the most common ENT emergencies, affecting almost 60% of the population, out of which 6% requires medical attention. Its peak incidence is seen in children less than 10 years and elderly people more than 40 years. The most common etiology is idiopathic, unknown, followed by primary neoplasm of the nose and traumatic causes. So this is one of the photograph of a patient who presented to our ENT department with bleeding from right nasal cavity. So coming to the vascular anatomy of nose, as we know, nasal cavity is extremely vascular. Terminal branches of external carotid and internal carotid artery supply the mucosa of nasal cavity and frequent anastomosis between these systems, out of which sphenopalatine artery is the most important supply to nasal cavity. So sphenopalatine artery is known as the artery of epistaxis. Here you can see the vascular supply of nasal septum. So anterosuperiorly, it is supplied by the anterior ethmoidal artery and posterior-superiorly by the posterior ethmoidal artery. Both are branches of ophthalmic artery, and ophthalmic artery in turn is a branch of internal carotid artery. So antero-inferiorly, you can see it is supplied by the superior labial artery, which is a branch of facial artery. Facial artery in turn is a branch of external carotid artery. And also supplied by greater palatine artery and sphenopalatine artery. So as I said earlier, sphenopalatine artery is the most important artery in the vascular supply of nasal cavity. So after emerging out from the sphenopalatine foramen, it divides into two branches. One is medial branch, one is lateral branch. Medial branch will supply the septum and lateral branch will supply the lateral wall of the nose. So endoscopic anatomy is also important in epistaxis management. So whenever we are doing the diagnostic nasal endoscopy, we have to do 3 passes. So here you can see this is the photograph of endoscopic picture of a left nasal cavity. Medially you can see the septum. Laterally what you are seeing is the inferior turbinate, IT, and MT is the middle turbinate. So in first pass, we will pass the endoscope between the septum and the inferior turbinate, starting from the anterior nasal layer up to the choana. So here you can see the first diagram is showing choana. This is the choana. And this is a more closer pic which is showing eustachian tube opening, tubal elevation behind the eustachian tube opening, and the marked area is the fossa of Rosenmuller. So basically, the first pass helps us to understand about the septal anomalies like DNS per inferior turbinate and abnormalities like turbinate hypertrophy and also nasopharynx. Coming to the second pass, so after returning from the choana, we will pass the endoscope medial to the middle turbinate, that is between the septum and the middle turbinate to visualize superior turbinate and the sphenoethmoidal recess. So second pass is mainly to visualize the superior turbinate and sphenoethmoidal recess. Coming to the third pass is mainly aiming at middle meatus. So we will go lateral to middle turbinate. So in second pass, we are going medial to middle turbinate, and in third pass, lateral to middle turbinate. So the marked area is the area of nasolacrimal duct, behind which you can see a sickle-shaped structure, which is the uncinate process, behind which there is a projection, which is the bulla ethmodalis. AG is the agarnase cell. So third pass mainly aims at osteomeatal complex. So this is the brief anatomy, endoscopic anatomy of nose. Now coming to the key clinical areas. First one is the Little's area or Kisselback's plexus. It is an arterial plexus seen in the antero-inferior part of the septum. It was first identified by James Little in 1879 and described 1 year later by the Kisselback. And it is the most common site of arterial epistaxis. In this figure, you can see Kisselback plexus is formed by anterior ethmoidal artery, greater palatine artery, superior labial artery, and sphenopalatine artery. This area is highly exposed to temperature variation, moisture variation, and the mucosa is very fragile. That's why it is the most common site of arterial epistaxis in children. Second one is the Woodruff's plexus, otherwise known as the nasopharyngeal plexus. It is seen in the posterior end of the lateral wall of the nose. That means inferior to the posterior end of inferior turbinate. So it is situated posteriorly, so it is a frequent source of posterior epistaxis. Sphenopalatine foramen. Sphenopalatine foramen is important in the ligation of sphenopalatine artery. So crista ethmoidalis is the bony projection which is seen anterior to sphenopalatine artery, and we are a sphenopalatine foramen, and we are using crista ethmoidalis as the surgical landmark for identification of sphenopalatine foramen. Coming to the vascular anatomy of inferior turbinate, usually inferior turbinectomy, the surgeries of inferior turbinate usually predisposes to postoperative hemorrhage because inferior turbinate is supplied by an artery which is known as the inferior turbinate artery, which is a branch of sphenopalatine artery. It runs submucosally, and on reaching the inferior turbinate, it divides into 3 parallel branches which run in bony tunnels within the submucosa. And these tunnels with their periarterial cuff of fibrous tissue and venous elements may prevent the artery constricting following turbinectomy. That is the reason for postoperative hemorrhage. Next one is the retrocolumella vein. Retrocolumella means behind the columella. It is seen 2 mm behind the columella, and it is the most common site of venous epistaxis in children. And one more area is there, which is known as the Brown's area, which is seen in the posterior end of the septum. This figure is showing Woodruff's plexus. So this is the nasopharynx, NP, inferior turbinate, posterior end you can see. So this is basically right nasal cavity. So lateral to inferior turbinate, you can see the inferior meatal region. The arterial plexus is known as the Woodruff's plexus. Now coming to the classification of epistaxis. Epistaxis can be classified according to age, according to the cause of epistaxis, and also according to the site of source of bleeding. So according to age, it can be classified into childhood and adult. Childhood means epistaxis in people less than 16 years, and adult means more than 16 years. And primary and secondary means, there is no definitive cause for epistaxis, which is idiopathic. 60 to 70% of epistaxis is primary. Secondary means there will be a definitive cause. Now, anterior and posterior means, anterior epistaxis means the bleeding will be from a source which is anterior to the plane of pyriform aperture. So, pyriform aperture is a defect or foramen present in the bony skull, and it is formed between the nasal bone and maxilla. So, any bleeding which is coming anterior to this region, that means from the columella, from the mucocutaneous junction, will cause anterior epistaxis. The importance is that anterior epistaxis is very easy to locate, and it is not at all a challenge for the clinician. But when the bleeding happens posterior to this pyriform aperture, it will be very difficult to localize the bleeding with headlamp examination. So we need the help of an endoscope for localizing posterior epistaxis. And it is most commonly found in adult people. Now, etiological evidence of adult primary epistaxis. So, as I told already, primary epistaxis means idiopathic epistaxis. But there are certain associations, clinically proven associations, like it is more common in autumn season and winter months. And it is associated with the use of NSAIDs due to its anti-platelet aggregation effect. And also alcohol intake can prolong the bleeding time despite normal platelet count and coagulation factor activity. So while taking the history from the patient, you have to ask about any drug intake which predisposes to epistaxis and also alcohol intake within 24 hours. Now coming to the selected causes of epistaxis, it could be local causes, that is from nose, paranasal sinus, nasopharynx, or it could be some systemic generalized disorders. So in local causes, most important thing is trauma. It could be a single digital manipulation, digital trauma, or it could be some nasal bone fracture, ethmoidal fracture, etc. Inflammatory or infectious conditions like allergic rhinitis, atrophic rhinitis, rhinosinusitis, granulomatous diseases like Wegener's granulomatosis, tuberculosis, midline lethal granuloma, and exposure to environmental irritants like smoke, fumes, or some chemicals. Then postoperative also, iatrogenic trauma. Like after nasal surgery, if there is ethmoidal artery injury, patient can present with retroorbital hemorrhage. That is an example. And also, I told already about inferior turbinectomy. So it can also predispose to post-op hemorrhage. Then neoplasm. Any tumor like benign or malignant tumor of the nose, like hemangioma of the septum, hemangiopericytoma, JNA, juvenile nasopharyngeal angiofibroma. When an adolescent male patient coming with unilateral nasal bleeding, you have to suspect JNA first. Or some esthesioneuroblastoma, all these conditions can predispose the patient to epistaxis. And structural deformities of the septum, like DNS, spur, and some drugs intake, like clopidogrel, warfarin, or salicylates, as I already told, NSAIDs, all these can predispose to aspirin, all these can predispose to epistaxis. Coming to the general disorders, hypertension, arterial sclerosis, these are examples for, this will predispose to posterior epistaxis usually. Any kind of platelet deficiency like thrombocytopenia or any kind of coagulopathies. It could be primary or secondary coagulopathies. Hemophilia, von Willebrand diseases are primary coagulopathies, or it could be due to secondary due to some kidney failure or liver failure, leukemia, or congenital causes like HHD, that is hereditary hemorrhagic telangiectasia, or Osler-Weber-Rendu disease. It's an autosomal dominant disorder which will predispose to mucosal bleeding. There will be telangiectasia, aneurysm, or AV malformation in this congenital condition. Then organ failure can also lead to epistaxis. So it is important to rule out the cause of epistaxis for the management of the condition. So these are some photographs. This is a vascular neoplasm of the nasal cavity. This is a tumor of nasal cavity. These patients presented to our department with bleeding, nasal bleeding. So coming to the most important part, the management includes resuscitation of the patient first. You have to take a primary survey, address the airway, oxygen supplementation if needed, and if there is a hemodynamic compromise, you have to stabilize the patient hemodynamically. You have to secure 2 large bore IV cannulas. So this is the management protocol for epistaxis patient. I'll come to this slider later. Now, there should be a stepwise approach. First thing is the initial assessment of the patient. Patient should be assessed in a semi-recumbent position, and nursing assistance is mandatory. Everyone involved, like doctor, nurses, should wear protective visors and clothing, as blood aerosol contamination is common, especially when inserting nasal packs. And the basic equipments include couch or reclining chair for the patient, headlight for nose examination, suction apparatus for removal of the clothes, and vasoconstrictor solutions, either lignocaine or adrenaline for topical anesthesia. Nasal packs. Nasal packs, you can use either conventional ribbon gauze or Merocil packs or balloon catheters you can use. And cautery apparatus. Cautery apparatus is mainly for the cauterization of the bleeding vessel. Once you locate the bleeding vessel, you can cauterize it. And nasal endoscopy equipments. So 2 things are important. The amount of blood loss. So you should ask the patient whether it is enough blood is there to soak the handkerchief, face cloth, or towel, and over what period. Because a minor but regular bleed can also cause anemia. Then clinical assessment of the cardiac status and circulatory blood volume is important. If the patient is having sweating, peripheral cool extremities, and also tachycardia. If there is features of significant hypovolemia, you have to proceed with blood transfusion. So as I already told, IV access is important. Securing IV access is important, and checking and correcting any clotting abnormalities. Then taking blood to find their blood group and save blood for future cross-matching that may be needed for transfusion. So patients admitted via the emergency department can be fast-tracked to ENT department if the patient is hemodynamically stable. So there are some criteria for fast-tracking the patient to ENT department. First one is the patient should be hemodynamically stable and shows no clinical signs secondary to hypoperfusion, like cardiac, respiratory, or decreased Glasgow Coma scale. The patient does not have any severe medical comorbidities that would make transfer to the otorhinolaryngology clinic or the ward unsafe. A complete blood count, clotting screen, and group and save blood for future cross-matching that may be needed for transfusion have been sent, and an intravenous infusion was started for other than minor bleeding. And Hippocratic technique or digital pressure on the patient's alar cartilages and septum has been used for at least 20 minutes. That is the first aid measure. So finding out the site and cause of bleeding is important in management of epistaxis. So the management can be classified under 3 headings. There is direct therapy, there is indirect therapy, there is surgical management. So direct therapy includes examination of the bleeding nasal cavity under headlamp, under local anesthesia. And if you are not finding the bleeding point with headlamp, you can use an endoscope. And if you find the blood vessel, you have to cauterize either it with chemical cautery like silver nitrate or with bipolar diathermy. That is the direct therapy. Next one is the indirect therapy. So if you find difficulty with direct therapy, you can proceed. If the patient has continued bleeding with direct therapy, you can proceed with indirect therapy, which includes anterior nasal packing, hot water irrigation, systemic or topical hemostatic agent. And surgical management includes posterior nasal packing, which is obsolete now, ligation techniques, septal surgeries, and the last resort will be embolization techniques. So the first aid measure is the Hippocratic technique. That means asking the patient to apply constant firm pressure over the lower non-bony part of the nose for 20 minutes. That means ala and the septum. Then lean forward. Ask the patient to lean forward with the mouth open over a bowl so that further blood loss can be estimated. This is known as Trotter's method. So the first diagram is wrong. The patient should lean forward with open mouth. Okay, that is the correct method. So the best clinical practice, first line therapy will be direct therapy. That is direct examination with headlamp or endoscope and cauterization of the bleeding vessel. So if the bleeding continues after first line, you have to go to second line therapy. That includes all the traditional procedures. That is anterior nasal packing, hot water irrigation, systemic or topical medical therapy. Then if a patient continues bleeding, then you have to go to third line. That is the surgical therapy. Actually, posterior nasal packing is not used much now. So we always prefer endoscopic sphenopalatine artery ligation over posterior nasal packing. And the last resort, that is the fourth line thing, is embolization. So direct therapy in detail. Once the clots have been evacuated under the headlamp examination, the nasal airway should be inspected. Then if the bleeding points can't be located, inspection with an endoscopy is warranted. Anterior epistaxis is usually very straightforward to identify, and 90% can be controlled either with chemical cautery or with electric diathermy, bipolar diathermy. The use of packing for anterior epistaxis is unwarranted and should be strongly discouraged because it's very discomfort for the patient and it's very painful, and again you will cause more mucosal damage by packing. So endoscopy identifies the source of posterior epistaxis in over 80% of the cases. Success rate for immediate control by endoscopic guidance are consistently reported in the 90% range. But you should not use monopolar diathermy because there have been reports of blindness due to current propagation. So always use bipolar diathermy for coagulation of vessel. So this is a diagram of diagnostic nasal endoscopy in the sitting position. So that's the endoscope, nasal endoscope, 0-degree nasal endoscope, and you can see the monitor also in the picture. So in the monitor, it is showing the right nasal cavity and there is an anterior cartilaginous deviation of the septum. You can see in that figure. So you can perform the endoscopy in the lying down position also. This is the endoscopic diagram of one posterior epistaxis case and suction apparatus. You can see suction also. Now coming to the indirect therapy, failure to find the bleeding point is an indication for use of one of the numerous traditionally favored indirect strategies. First one is anterior nasal packing. Skills required for accurate packing are difficult to acquire, and with modern techniques of nasal surgery less frequently encountered in surgeons' training. So we can use either ribbon gauze impregnated with petroleum jelly or BIP. BIP is bismuth iodoform paraffin paste. Here bismuth will act as an antibacterial agent, iodine will act as antiseptic, and paraffin will act as a lubricant agent. Or you can say merosil. Merosil is a compressed polymer, polyvinyl acetaldehyde, which can also be used, and balloon catheters can be used. In our department, we are using ribbon gauze or merosil soaked in soframycin ointment. Once packed, the packs are left in situ for 24 to 48 hours. So this is the picture showing merosil. This is the merosil packing, and you can see one tie there. It helps in the removal later. So this is anterior nasal packing of both nasal cavities with merosil. So this is the diagram showing the conventional anterior nasal packing. Here you can see the ribbon gauze is there. It can be done in vertical layers or also in horizontal layers. So the first layer should be along the floor of the nasal cavity. Then you can pack either vertically from backwards to forwards, or you can you can do in horizontal layers from downwards to upwards also you can do. This is posterior nasal packing. The figure 33.4 is posterior nasal packing. I'll discuss it later. So rebleeding with packs in situ is observed in up to 40% of cases. So if anterior nasal packing fails, a posterior balloon may be placed and inflated in the postnasal space. Instead of posterior balloon, you can use Foley's catheter also. An anterior packing is then placed and then gentle traction is used to pull the balloon forward against the anterior nasal packing. This is held in place by a clip over catheter anteriorly as it emerges through the anterior packing. So it is vital that any clip used to secure the catheter does not rest on the skin of nostril because it can produce necrosis of the area in less than 4 hours. And to avoid the toxic shock syndrome, we have to start the patient on systemic antibiotics prophylactically. So the complications associated with nasal packing includes sinusitis because we are obstructing the drainage pathway of paranasal sinuses, and septal perforation, ala necrosis, hypoxia, and myocardial infarction. There is no clear, universally agreed definition of failed packing, but patients who continue to bleed should proceed to surgical management sooner rather than later. All admitted epistaxis patients should be hemostased within 24 hours of admission. If this has not been achieved, a rhinologist should be summoned to review the case. Patient should not be left in a ward with blood oozing from the nasal pack. So that's about anterior nasal packing. Now coming to the second indirect method, that is hot water irrigation. The mechanism is when you irrigate the nasal cavity with hot water, vasodilatation happens. It will predispose to mucosal edema and local compression of the blood vessel, and that will propagate the cascade for hemostasis. So the procedure is, first you have to anesthetize the nasal cavity with 4% lignocaine topically. Then examine with nasal endoscope. Then a specific bladder catheter is inserted into the affected nasal cavity. Stangerup's modified bladder catheter. Then the balloon is inflated and catheter is gently pulled back until choana is blocked off. Then you have to irrigate the balloon with tap water 50 degrees Celsius until bleeding decreases for 3 minutes. So after irrigation with 500 ml of hot water, catheter can be removed. So the advantage of hot water irrigation over anterior nasal packing is that it avoids the painful packing and hospitalization or immediate surgery, and also allows the patient to breathe normally through an open nasal cavity after treatment. Now, the systemic medical therapy includes tranexamic acid, epsilon aminocaproic acid. These are systemic inhibitors of fibrinolysis. The recommended dosage is 1.5 gram 3 times daily. But pre-existing thromboembolic disease is a contraindication. Instead, you can use topical hemostatic agents like Flocin or Botroclot nasal drops. Botroclot nasal drop is nothing but hemocoagulase solution. This can also be used. Now, coming to the posterior nasal packing, as I said already, it is largely obsolete now. In extreme cases where no specialist rhinologist is available, it may be indicated. So, general anesthesia is preferred. We can use special gauze pack. So, I'll show you the picture. So, here you can see there is a gauze pack which is rolled into the shape of a cone. This is a second picture, down picture. So, there are 3 ties. 2 ties are there and 1 tie is there. So first we will pass a rubber catheter through the nasal cavity, and the other end is taken out through the oropharynx and it is brought out through the oral cavity. 2 ties are tied to this end, and when you withdraw this rubber catheter through the nasal cavity, out of the nasal cavity, this ribbon goes, the goes in the shape of a cone will follow this rubber catheter, and with the use of index finger, you can push that goes back into the nasopharynx. After that, after taking out the 2 ties, you can pack and you can do anterior nasal packing either in vertical or horizontal layers, and you can tie these 2 ties to a dental rod. And the single tie can be allowed to hang in the oropharynx, which will help in easy removal later. Okay. So, special gauze packs can be used. A posterior nasal packing is first prepared by tying 3 silk ties to a piece of gauze rolled into the shape of a cone. A rubber catheter is passed through the nose and its end is brought out from the mouth. Ends of the silk threads are tied to it and catheter withdrawn from the nose. Pack which follows the silk thread is now guided into the nasopharynx with index finger. Anterior nasal cavity is now packed and silk threads are tied over a dental rod. Silk thread is cut short and allowed to hang in oropharynx. It helps in the easy removal of the pack later. So instead of this gauze pack, you can use either 12 or 14 size Foley's catheter also. Insert Foley's catheter along nasal cavity floor until nasopharynx is reached. After insertion, the balloon bulb is inflated with 5 to 10 ml of saline and pulled forward so that choana is blocked. And then anterior nasal packing is kept in usual manner. But the complications with posterior packing are pain, hypoxia secondary to soft palate edema, sinusitis, middle ear effusion, necrosis of the septum and columella. So it has been stated that gone are the days when a patient had an uncomfortable posterior nasal packing inserted, then spent several days on the ward only to bleed again on its removal. So endoscopic sphenopalatine artery ligation or SPAL has replaced posterior nasal packing. So instead of this Foley's catheter, you can use balloon catheter also. There are 2 balloons. The posterior one is filled with 10 ml saline and the anterior one with 30 ml saline, and catheter provides the nasal airway. So when you are securing the catheter anteriorly, you should avoid the necrosis of the skin of the nostril. So that's about posterior nasal packing. Now coming to next technique, ligation techniques. Ligation is reserved for intractable bleeding where the source cannot be located or controlled by techniques described above. So there is a hierarchy for ligation. First, you have to ligate sphenopalatine artery. So if bleeding continues, you have to ligate internal maxillary artery, followed by external carotid artery. And if there is a confirmed ethmoidal bleeding, you should ligate anterior or posterior ethmoidal artery. So coming to endoscopic sphenopalatine artery ligation, it can be done either under general anesthesia or local anesthesia. So our aim is to find the sphenopalatine artery when it emerges out of the sphenopalatine foramen and ligate it. So incision is given 8 millimeter anterior to the posterior end of middle terminate. Incision is deepened up to the bone. Mucosal flap is elevated posteriorly until the neurovascular sleeve arising from the sphenopalatine foramen is identified. I told you already, crista ethmodalis, that the bony projection is a surgical landmark for identifying sphenopalatine foramen. So once the vessel is identified, it can be coagulated using bipolar diathermy. So this is the endoscopic picture. Here it is marked. You can see the crista ethmodalis, and posterior to that sphenopalatine foramen is identified. So the complications associated with this procedure include nasal crusting, palatal numbness, acute sinusitis, decreased lacrimation, septal perforation, or rebleeding can also happen. So internal maxillary artery ligation. There are two different approaches. One is sublabial approach. One is that is otherwise known as anterior approach, and also one endoscopic approach is there, which is combined anteromedial approach. So the aim is to locate internal maxillary artery in the pterygopalatine fossa within the fat. So pterygopalatine fossa is located posterior to the maxillary sinus. So sublabially we will do androstomy, maxillary androstomy. You should be careful to preserve the infraorbital nerve. Then you have to create a window in the posterior wall of the maxillary antrum to reach the pterygopalatine fossa. PPF is pterygopalatine fossa. Then internal maxillary artery pulsating within the fat fossa should be ligated. So the complications are, you are going sublabially. So dental damage can be there, oroantral fistula, damage to infraorbital nerve and leading to numbness of the cheek, or sinusitis can happen. Now, external carotid artery ligation, you have to give a longitudinal incision parallel to the anterior bone of sternocleidomastoid. Identify the carotid bifurcation, identify external carotid artery and its branches, and ligate the vessel. Complications are wound infection, hematoma, or neurovascular damage. Now, anterior or posterior ethmoidal artery ligation. It is usually done in confirmed ethmoidal bleeding. So, ethmoidal bleeding can happen either in naso-orbito-ethmoidal fractures, or it can happen after nasal surgery. So, when there is a bleeding from anterior ethmoidal artery, it will retract into the orbit and cause retroorbital hemorrhage. So that is a surgical emergency. You have to decompress the orbit first, and then you should proceed with ligation of the artery. So you can do either open approach or you can approach endoscopically. Open approach means you have to give a medial canthal incision, and anterior ethmoidal artery is usually found 1 to 2 millimeter behind the junction of the posterior wall of the frontal recess and anterior ethmoidal cells, and posterior ethmoidal artery will be 12 millimeter behind the anterior ethmoidal artery. So first you have to locate anterior ethmoidal artery, ligate it, go 12 millimeter behind that and find the posterior ethmoidal artery. So these are the ligation techniques in hierarchy. Now coming to septal surgeries. So when the cause of bleeding is DNS or a spur, you can do septal surgery as the definitive treatment. But septal surgery can also act as a primary treatment for failed packing. How? The rationale is that by elevating the mucoperichondrial flap for septal surgeries like septoplasty or submucous resection, the blood supply to the septum is interrupted and hemostasis is secured. Now, the last resort is embolization. We would advocate the use of arterial embolization technique for patients with refractory epistaxis who are unfit for surgery or in whom surgery has failed to control the bleeding. Done under LA, transfemoral Seldinger angiography is used to identify the bleeding points. It is essential to exclude AV malformation, aneurysm, and fistula prior to the embolization. So once you identify the bleeding vessel, you can a fine catheter is passed into the internal maxillary artery circulation, and the embolization agents like polyvinyl alcohol, tungsten, or steel microcoils are used to embolize the vessels. Ipsilateral facial artery is also embolized in order to prevent the recirculation. So the complications are skin necrosis can happen, paresthesia, cerebrovascular accidents, or growing hematoma. So now we will see the management protocol. So the first thing is resuscitation of the patient. First, you have to resuscitate the patient. This is the flowchart. And initial examination. So by initial examination means examination with the head lamp. So if the vessel is located, you can go with direct therapy. That is either chemical cautery or bipolar diathermy. If the vessel is not located, you have to use an endoscope for examination of the nasal cavity, bleeding nasal cavity. So with endoscope, you are localizing the vessel and again you are going with direct therapy. But if you are not able to visualize the blood vessel with or localize the blood vessel with endoscope, or if your direct therapy fails, if your bipolar diathermy fails, you have to go with indirect therapy, that is anterior nasal packing. So if it controls with anterior nasal packing, you can keep the pack for 24 to 48 hours minimum with antibiotic coverage. But if it bleeds even after anterior nasal packing, you can do an extra posterior nasal packing also, or septal surgery or ligation techniques. And if the patient bleeds after anterior pack removal after 48 hours also, you have to proceed with posterior nasal packing or septal surgery or ligation. And if the patient continues bleeding even after ligation techniques, you have to go to the last resort, that is angiography and embolization. And you have to look for the secondary factors also. So this is the protocol, which is taken from the standard textbook of ENT, Scott Brown. Now, so the conclusion is that you have to assess the patient and you have to ask the patient to do first aid techniques, that is Hippocratic technique and Trotter's method, and resuscitation if necessary, and establish IV cannula, IV access, and treat any clotting disorder which would preclude surgery. And if there is a naso-ethmoid fracture with anterior ethmoid artery bleeding, you have to proceed with ligation surgery. Then headlamp examination after removing the clothes, and proceed with the silver nitrate cautery or bipolar diathermy. If hemostasis is achieved, you can discharge the patient and instruct to use the petroleum jelly or any nasal ointments 3 times daily for 10 days. But if you are unable to stop, call an experienced endoscopist if readily available. If not available, you can proceed with packing. But if the endoscopist is available, he can do endoscopy and bipolar diathermy. But if it bleeds again you have to pack and avoid mucosal damage. Wait for 12 to 24 hours. If bleeding continues or if it restarts when pack is removed, you have to go with sphenopalatine artery ligation. And consider septoplasty and or partial ethmoidectomy for better visualization. And the last resort is angiography and embolization if needed. So these are my references. I hope you understood the topic. Thank you so much.